So MGD, my Miller Genuine Draft.
Oh yes. Oh, if only my 5 o'clock patient could be that MGD, I would love it. I would love it.
All right, let's welcome first of all. How's your coffee?
It's good. Well, you know, matcha.
Yeah.
Pretty drinks are what win, Nate.
Yes, exactly. I'm more into the function of the drink and its
You're glaucoma, so I don't blame you.
Yeah, it's all about its pharmacological effects. But you know, I do. You're an expert on dry eye, anterior segment, cornea, cataract. I could go on, but I wanted to talk to you a little bit about meibomian gland dysfunction, and you know, what is the average doctor sort of needing to brush up on these days with this condition and how it affects our patients and our outcomes?
I mean, I think we just see such like a growing rate of MGD. I think before it used to be thought of kind of an old person disease, you know, you live this life, your glands start to clog up, maybe it affects your vision, you know, maybe your eyelids look gross, and then you kind of try your best with lid hygiene and move on. But I think it's really changed. I think the etiologies of why people get blepharitis have changed. I think we're honing in a little better with what symptoms are. Like before I would just look for it, but now I listen a little more. And then I think with anything else, like we have treatments now. If we have treatment options, we're suddenly listening a little more and looking for more of the diagnosis. It's always hard to find something and be like, I have nothing to offer you except like, here's a mask, good luck. But now I think we have more options to actually treat the symptoms. So it's a new world, I think, for MGD. And I think for that reason, the average practitioner should lean in a little bit more too. I mean, I think we've all heard the whole, like, I really don't want to treat dry eye. Like, I really don't want to treat blepharitis, but I think we all have to, right?
You know, it's funny you say that. The first part of my career, I was always focused on the clinical exam. I'm just kind of trying to get good at that if possible. Now I focus on like listening to what the patient says. So what are the things that they might say that make you think it's MGD in particular, or that there's a big component of MGD?
Yeah, I mean, the tough thing I think with MGD is they don't come to you and say, my lids are clogged. You know, I mean, if you had a skin issue, they would say something like that, but they can't see their lids. And so one of the most important things that I listen for are symptoms of tear breakup time. Things like fluctuating vision, or, you know, sometimes when I'm reading, things start to blur out after a couple of seconds, or you know, at the end of the day, I just don't feel as clear. You know, patients will come for cataract eval. Like, how many times have you heard them be like, I'm here for my cataract eval. My vision fluctuates all day long. And you already know this is not a cataract eval anymore. This is an ocular surface issue.
Yeah, we have one of my OCT technicians will put a sticker on the chart if they need to add a drop while they're imaging for the OCT, because it's basically a tear breakup test.
Right, And I think, like, once I kind of connected the two and we learned a little bit more about it, when I stare now at their tear breakup time, I used to just count it, right? That's like we're taught, like counted 1, 2, 3. But now I can actually imagine, like, this is what the patient is seeing. Like, this is their windshield, right? Like, you can see it just dissipate in a couple of seconds. And I think when the providers start to think about that as like a functional thing, they can imagine it in their own eyes and they can see why it's so important to treat.
And then, by the way, here's the patient's vision is going bad and my topography image is going to garbage in my image this patient before surgery. So what are the things that you do when you sort of move to that treatment zone and try to get someone ready so that you can, you know, image their cornea and get ready for surgery?
We've actually kind of switched our approach for some patients. You know, we actually do a topography on every patient, and we do like the placido imaging. I think it can really tell a lot of information, little spaces where like the placido images have blanks or maybe irregularities. And when we see that, then we kind of stop the whole process of the cataract eval, even before calcs and stuff like that. Because nothing's worse than the patient and your technician going through the whole process. You've got your OCT, you've got your biometry, you've got your topography, and you're like, well, I got to start over again because none of this is any good for my surgery.
And even worse, you know, I said, don't scan this biometry. Destroy it immediately.
Don't put it in the chart. I don't care about that, like, 0.5 sil in that cornea. We need to treat it first.
And I don't want anyone using these numbers for anything.
Never again.
Okay, so it really is, it's an important part, and it kind of happens during that cataract workflow, workup in some patients, right?
It does. And I think also, like, it's not even just the cataract patients. I think we are really focused on surgical patients because it's us on the line, right? You know, they have an outcome that's not what we desired, and it's because of their tear breakup time. Maybe they have a little bit of worsening vision afterwards. We do bad things to the eye sometimes during, or make a wound, and make an incision. We do all this betadine, we put them on drops afterwards. And so sometimes we're disrupting their tear film, and we're making what's kind of a milder case a little worse. But I actually think it's really important for like all providers to lean in a little bit on blepharitis. Like we try to educate like our optometrists to really do that. I mean, it's very expensive to redo a pair of glasses. So like if I refract someone today, or my optometrist does, and it's like kind of incorrect because they have MGD and they have a tear breakup time, it's like 2 or 3 seconds. I mean, that costs the practice a lot, you know, and the patient has to come back for a redo on refraction. So I think it's just not really just cataract surgery, really. It's really all of those who provide vision care, because you can't really get the best refraction, the best contact lens, the best glasses, or the best surgery if you're not treating that tear breakup time and that tear film stability.
Yeah, and you know, of course, I'm sure this happens to you all the time, is you get someone who has cataracts, they have complaints, and you're about to operate, you know, or get them ready, and then they say something like, you know, yeah, my vision just comes and goes, and you're just, okay, we got to stop, right? The fluctuation's a big part of it. But then at the same time, maybe the patient has enough cataract, right? You know you are going to take it out. So the timing, right? No patient wants to really put off a cataract surgery they know they need. So how do you kind of get them in shape in a time that meets the patient's, you know, needs and expectations, but also make sure you're in a good place to get good numbers, get good outcomes, and have a patient be comfortable?
Yeah, and I will say, like, 2 of my favorite treatments, they're a little bit quicker for someone prepping for cataract surgery, or like an immunomodulator and like a low-dose steroid. You know, I think both of those, they work great in conjunction. They're a little quicker acting as far as the steroid goes. Immunomodulator, I kind of educate them. They may be on it for several months, if not long-term. We used to kind of hang by the studies that showed, you know, 1-month data, 3-month data. But I think it's great that we have newer studies that's showcasing that some of these treatment options, the immunomodulators, actually start working a lot quicker. If you think about it, like that perfect zone, I don't think any patient has ever gotten upset, especially when I show them their topography and explain the situation, that we're going to cancel surgery. But when you start saying it's going to take me 3 months until I can reschedule you, they start getting really nervous. I mean, you're like me. It takes a long time just to even get in for the eval. And so I think one of the nice things is saying, well, no, it's going to take a couple of weeks. So we'll bring you back. Maybe we'll use your second eye appointment for surgery for your first eye. We'll get you in there. And I think that combination of using some lid hygiene plus an immunomodulator plus a steroid, kind of, I see things turn around. Like topographies get better after just a couple of weeks. And so I think that's one of the keys too. We have such great immunomodulators out there. You know, we have agents that are like dual acting, like lifitegrast. We have low dose steroids that don't cause a steroid response right away. Because you'll be on me if that happens, you know?
I'll be totally forgiving.
Totally forgiving. But I think that's the key. I think we're not in the era we have to postpone it for 3 months. And if we have diagnostics, their cornea is never going to be perfect. I tell them that blepharitis, I mean, this issue that you have with your tears just not being really stable, they evaporate really quickly. This is lifelong. Like, we're going to have to deal with this. But what we want is stability of measurement so that we can move forward with surgery.
So how about, you know, we're talking about meibomian gland dysfunction. How about MIBO? I'm then particularly interested in hearing, you know, how it actually works, and then what your expectations are for that in terms of timing and, you know, the patient.
I mean, we know that blepharitis is kind of a lifelong type of process, and it's something where it can be really hard to treat the etiology, and some of it's a little bit irreversible. And so I think one of the keys with a product like MIBO is that we're treating what the patients are noticing, and that's something they really appreciate. So they come in with fluctuating vision, they come in with feelings and sensations that their eyes are burning, irritating, and then we're actually able to help them because of the way that medication works. And so I like to explain to the patient that, like, look, your tears break up very quickly. And I have a drop that can help you. It's almost like a coating agent for you. And it can offer you some stability to your vision. It may not last all day. You'll have to use it several times during the day. But then I have, you know, something for you that at least help what it is you're coming in for, which is fluctuating vision. And I think that goes a long way. And then when you meet a patient for the first time and you give them like a list of like 5 different things to do, and none of them actually address their fluctuating vision, it can be really challenging for them. Like they're just not sure where you're going with it. And I love immunomodulators, and I love talking to them about different ways to do like lid expression and such. But at the end of the day, if we have something that can treat the symptom they came in with, which MIBO can do, that's great. In my experience, the one other thing about it, and we've all gone through many, many ocular surface products. Most patients don't really complain about any of the adverse events or side effects for it. I have a few that are like, it kind of feels different, which makes sense. It's like a completely different molecule.
Yeah.
And for some people, they're like, I don't think it really helped me as much as I thought it would. But for all in all, at least we don't get those patient calls that are like, this burns terribly. What am I going to do with it? Or my eye is really stinging and red for like, or I have, weird sensations with it. And so I think that's the nice thing about it. I think you listen to our technicians a lot, and my techs are always like, sounds good. Yeah, you can prescribe that. But there are other medications where they're like, you sure you really want to prescribe this? Because they know they're going to get that patient phone call. And then we spend a ton of time educating the patient before they leave the room even about it.
Yeah, and for me anyway, in my practice, I think one of the ways that it's worked is just that, why don't patients take their glaucoma drops? Because their glaucoma doesn't get better in their mind right after they take the drop. And this is sort of the first dry eye therapy where there's like pretty immediate and lasting relief. And the patients just make that connection between the behavior of taking the drop and the improvement in their vision. And you start to see them develop their own routine or learn how to use it for that purpose. And it's just a positive feedback mechanism, but it's just something that practically like helps patients be compliant.
Yeah.
'Cause, we've all heard, cyclosporin compliance or refill rates can be 10%, in some studies. And like, that's concerning.
And I also find like that when it comes to ocular surface disease, I hope your glaucoma patients are better than this, but for ocular surface disease, it's really hard to have the patient take multiple therapies.
Yeah.
I think they can usually do 2.
Yeah.
I think once you start saying, hey, I need you to do this laundry list of things, even the best patient will be very faithful to it for the first few weeks. And then over time, you see that like they've taken one of them off this. And they're very sneaky about it. They just come for their follow-up. And then you're like, well, whatever happened to those 3 medicines I tried so hard, got you access on? And they're like, yeah, I kind of stopped using them. And so we have to also be realistic. If this is a lifelong disorder, if ocular surface issues are something that we have to treat, we want to limit how many different options. And I find with Miebo, because it treats the symptoms, that tends to be the one that's on the list that they're still using after a little while. I can maybe add another regimen to it as well, but if you can keep it to 2, maybe 3. But I can't imagine the glaucoma patients. I don't know where they fit it into their day of like, this color drop, that color drop. Are they kind of like, wait, Miebo has no color drop? Is this even a drop that has no cap color for you?
Yeah, they need the cap colors first of all.
Just how it defines it.
We need the cap colors. Somehow they always seem to lose their pilocarpine.
Yeah.
And they're like, my pilocarpine ran out. I'm like, oh no, that didn't. That's a 15 ml bottle. It'll be with you for a while.
Forever.
It's the confusion is a big part of it. And the term I use is like health literacy and, I had a rocket scientist patient who couldn't say dorzolamide timolol once. And I thought, well, now we're all doomed if this one.
That's a big word though.
They all are. And, so it's actually value brand names in all seriousness, because if they can say the name, pronounce it, it's going to help. It's going to help a lot of people. Thank you for talking to me about meibomian gland dysfunction, and now make you just a little uncomfortable and say, what is it do you think the glaucoma doctors aren't getting about MGD that we could do better with?
Oh, that's a tough one. I feel like the reality is that if there's an opportunity to add another drop, to stop. Like, I really do think so, because when I see somebody with ocular surface disease and they're on maximum medical treatment, I wish I could go in a time machine and go back to maybe when they were just on like 2 agents and that something would have intervened at that point in time. Because once they have that much of a drop burden and they've had it for a while, it's really hard, A, for me to add anything. Because when are they eating? Come on, how are we going to do that? And B, you've already seen some of the irreversible signs, the prostaglandin analog. You've seen what's happened with like things like Repressa and such. And so I think, I was definitely speaking to the choir here with you, but I think for glaucoma specialists, there should be like a little wall where they kind of stop and say, maybe I could intervene with something to avoid adding that 3rd or 4th agent.
Yeah, and I feel like the field is headed in that direction, but we need all the help we can get getting there. So keep spreading that message.
Absolutely, Nate. Absolutely.
Okay. Thanks for having coffee.
Oh, so much fun, buddy. Cheers.